Welcome to a very special deep dive into one of the most fundamental yet constantly evolving aspects of modern medicine, consent. Today, we're going far beyond just the forms. We're exploring the profound shifts in legal, ethical, and practical obligations that now shape, well, every single patient encounter you have. This conversation is absolutely crucial for any medical professional grappling with the complexities of patient autonomy and the ever-present pressures of clinical practice, especially for those of you in orthopedics. We're going to unpack the landmark legal judgments that have truly redefined patient-doctor relationships, delve into the unique, high-stakes challenges faced in fields like organ transplantation, and then confront a pervasive, often subtle phenomenon, defensive healthcare practice. It's about understanding not just what we must do, but why it truly matters, and how you can navigate these intricate landscapes without compromising optimal patient care. You're trying to give your patients the best, and we want to help you understand how to do that within this complex environment. I'm delighted to be joined by Professor Mo Imam, whose exceptional expertise will guide us through these fascinating and critical developments. Professor Imam, let's dive straight in. Consent used to feel perhaps more straightforward, maybe more doctor-led. How has our understanding and the legal framework around consent truly evolved, particularly here in the UK?
That's a great starting point. And yes, you're right. The concept of consent has, without exaggeration, undergone a massive transformation. Historically, there was an implicit understanding, almost a sort of social contract, where a doctor might act for the patient's own good, sometimes, crucially, without full disclosure. This paternalistic approach, where medical professionals were largely presumed to know best and make decisions on behalf of their patients, well, it really dominated for decades, even centuries. Now it's universally accepted that a patient must provide appropriately informed consent before any therapeutic intervention. But, the intricacies of different medical conditions inherently present varied issues for both clinicians and patients. For consent to be legally valid today, you're looking at several core elements. Firstly, capacity. The patient must possess the mental capacity to make the decision, as defined, for instance, by the Mental Capacity Act 2005 in England and Wales. Secondly, voluntariness. The decision must be made freely, without any coercion or undue influence from any party. Thirdly, choice. The patient must understand the availability of all reasonable therapeutic options, allowing for a meaningful rather than sort of token choice. And finally, there must be a comprehensive disclosure of material risks. All material risks and other relevant information must be communicated to the patient. It's quite a high bar.
Those four core elements, capacity, voluntariness, choice, and disclosure, are truly the bedrock. For our listeners navigating this daily, which one of these, in your experience, is the most consistently challenging to truly achieve in practice, and why?
That's an excellent question. It really gets to the heart of the practical challenge. Whilst capacity and voluntariness can certainly be complex, I'd argue that disclosure of material risks and ensuring true choice are often the most difficult in day-to-day practice. It's not just about listing risks, you see. It's about conveying their significance in a way that resonates with that particular patient.
Making it real for them.
Exactly. And choice isn't just about having options on paper, but understanding them in sufficient depth to make a genuinely autonomous decision. We often see a disconnect between what we tell patients and what they actually absorb and apply. And just to put this into historical context, to really underline that shift, let's look at the landmark UK case of Hatcher v. Black from 1954. A patient, a BBC broadcaster, was advised to undergo a thyroidectomy. She specifically inquired about risks to her voice, absolutely critical for her profession, obviously. The surgeon, however, falsely reassured her there was no risk, despite knowing otherwise. Tragically, her recurrent laryngeal nerve was damaged during the surgery, affecting her voice so severely she never broadcast again. The court at the time, quite remarkably, accepted the surgeon had lied for her own good, stating, as far as the law is concerned, it's not condemn the doctor when he only does what many a wise man and good doctor so placed would do. This judgment vividly illustrates the deeply paternalistic mindset that once prevailed in medical practice, and indeed in legal interpretations of a doctor's duty.
Wow, so Hatcher v. Black truly paints a picture of a bygone era where doctor knows best was the prevailing wisdom, even legally. That's quite something. But that set the stage for a seismic shift, didn't it? Because in 2015, we saw what many are calling a revolution in patient-doctor relationships with the Montgomery judgment. Professor Imam, what made this ruling so utterly transformative?
You're absolutely right to call it a revolution. Montgomery v. Lanarkshire Health Board was without doubt a landmark ruling. It profoundly reshaped the doctor-patient relationship and the legal standard of disclosure here in the UK. The Supreme Court unambiguously rejected the paternalistic model we just discussed. It established patients as co-decision makers in their own healthcare journeys. This meant that a patient's autonomy and individual beliefs are now considered central to medical decision-making, rather than merely being secondary to a doctor's expert opinion. It, it flipped the script entirely. A crucial element of this judgment was the introduction of a new, genuinely patient-centered test for material risk. So a risk is now deemed material if, firstly, a reasonable person in the patient's position would likely attach significance to it, or secondly, if the doctor is or should reasonably be aware that this particular patient would likely attach significance to it. This moves us far beyond rigid objective percentages. For instance, in an earlier case like Tasman v. Bart's Health Trust, a 1 in 1,000 risk was deemed non-material. But the Montgomery test explicitly allows for the subjective values and concerns of an individual patient to determine materiality.
Ah, so the specific patient matters.
Precisely. This means a seemingly small statistical risk could be highly material to a specific patient because of their unique circumstances, their specific fears, or their life priorities. It demands a much more individualized conversation.
So the true nugget here is that Montgomery shifted the burden from what doctors think is important to what patients find significant, a fundamental reorientation. What's the most surprising practical implication of that shift for day-to-day practice?
Well, I think the most surprising, or perhaps the most impactful practical implication, is the mandatory emphasis on dialogue and alternatives. The court underscored the necessity of a genuine, open discussion, not a one-way information dump. Lady Hale, in her judgment, she emphasized that a doctor's advisory role involves considering not just the proposed procedure itself, but also its alternatives and the arguments for and against each of those options. This is all to protect a person's fundamental interest in their own physical and psychiatric integrity and their freedom to decide what happens to their body.
So empowering patients, really.
Yes, empowering patients with the full spectrum of choices, even if those choices are uncomfortable, or frankly, time-consuming to explain. It fundamentally changes the dynamic from, here's what I recommend, to, here are options, let's discuss what's best for you. Importantly, Montgomery effectively repudiated the Bolam test in the context of information disclosure. Prior to Montgomery, the Bolam test, which basically said a doctor isn't negligent if their practice aligns with a responsible body of medical opinion, was often applied to how much information a patient should be given. This new ruling marked a significant departure from earlier cases, like Sidaway, which had relied on Bolam for risk disclosure. So, what a body of doctors might historically have considered standard disclosure is no longer sufficient if it doesn't meet the patient-centered standards set by Montgomery.
So you can't just hide behind standard practice anymore for disclosure.
Not for disclosure, no. Your peer's practice is no longer your sole defense for what you disclose. And whilst the GMC's professional guidance, dating back to 2008 and 2013, already promoted a patient-centered approach, Montgomery cemented this as a clear legal obligation. The Supreme Court acknowledged the GMC's influence, but stated it was necessary to impose legal obligations so that even those doctors who have less skill or inclination for communication, or who are more hurried, are obliged to pause and engage in the discussion which the law requires.
So it's a legal duty now, not just best practice.
Absolutely. It underscores that it's not just good practice, but a legally binding duty, pushing everyone towards a higher standard of communication.
So what does this all mean for us in orthopedic practice? We often deal with elective surgeries, reconstructive procedures, trauma. The options and risks can be highly specific and varied. How does this patient-centered dialogue translate into our day-to-day work on the wards and in clinics?
Well, in orthopedics, this shift is incredibly pertinent. The British Orthopaedic Association, the BOA, their guidelines implicitly acknowledge this. The consent form itself becomes less important than the quality of the dialogue. When patients sign an orthopedic consent form, they will inevitably have questions, and those must be answered fully and honestly. The focus has to be on an ongoing dialogue tailored to the individual patient, rather than just seeing the signed form as conclusive evidence of valid consent.
So it's a process, not just a signature.
It's absolutely a process, not just a signature on a piece of paper. Think about it. Think about an orthopedic patient considering, say, a total hip replacement versus a resurfacing, or different methods of fixing a complex fracture. These patients often face a range of choices. Different surgical approaches, non-surgical management, various implant options. Montgomery mandates a thorough discussion of all these alternatives, their respective risks, their anticipated benefits, and crucially, how they align with the patient's personal values, lifestyle, and desired outcomes. For instance, a keen amateur athlete might value a quicker return to high-impact activity, while an older, less active patient might prioritize long-term durability with minimal disruption.
Totally different priorities.
Completely. These lifestyle factors significantly influence their choice of treatment, and our discussions must reflect that personalization. It's no longer enough to just list the generic pros and cons. You need to understand their pros and cons.
Moving now to an area where these complexities are amplified exponentially, organ transplantation. Professor Mom, why is obtaining truly informed consent here even more challenging than in many other medical interventions? It sounds like an entirely different league of difficulty.
It really is. Transplantation presents a unique confluence of exceptionally high stakes, profound patient vulnerability, and frankly, an immense informational burden that far exceeds most other medical interventions. Patients waiting transplantation are often critically ill, frequently, teetering on the edge of life and death. Their ability to receive, understand, and process complex information can be significantly affected by the underlying organ failure itself. For example, individuals with advanced renal or liver disease may suffer from encephalopathy, or those with severe heart or lung disease may experience hypoxia. These conditions, or the heavy medications they require, can impair cognitive function. What's more, this encephalopathy may not always be clinically obvious and can fluctuate in severity over time, making a consistent assessment of capacity incredibly challenging. And then there's the sheer volume of information a patient needs to be considered fully informed. It's immense. They need to grasp the implications of not proceeding with transplantation, the immediate risks and consequences of the transplant procedure itself, and the short and long-term consequences of living with a transplant. This includes increased risks of death, graft failure perhaps from immune damage, infection, the development of new malignancies, or cardiovascular disease. Then there's the absolute necessity for lifelong immunosuppression.
Which comes with its own set of issues.
Absolutely. Its inherent consequences and the need for constant monitoring, alongside significant lifestyle limitations, things like the need for long-term care, avoiding unnecessary risks, smoking cessation, and potential teratogenicity, the potential to cause developmental abnormalities in a fetus for those of reproductive age. It's a huge commitment. Beyond their own body, patients must also understand the specific risks associated with the donor organ. This includes the potential transmission of infection or malignancy, which could be known or even unintentional. Organ-specific risks also vary dramatically. For example, organs from donors after circulatory death, or perhaps those from obese donors, are statistically more likely to fail. Then there are the extensive risks associated with immunosuppression itself. These are both drug-specific. Tacrolimus alone lists 63 side effects.
63.
63 listed side effects, yes. And generic risks, including an increased risk of certain cancers, infections, and cardiovascular or renal toxicity. Patients also face the ongoing risks of recurrent disease and early or late rejection of the organ. It's a mountain of information.
63 side effects for a single drug. That's an incredible informational burden, especially for someone critically ill. For our orthopedic audience who might deal with similar complexities in managing multiple medications, how do you even begin to distill that vast amount of information without overwhelming patients or fostering defensive overdisclosure?
It's a huge challenge. And actually, to add another layer of complexity, these critical decisions often have to be made in the small hours of the night. That's when most organ offers occur. This adds immense time pressure to an already complex situation, requiring rapid comprehension and decision-making when patients are often least able to process information. Many risks are also hard to quantify objectively. We often rely on historical data, which may be outdated due to advances in treatment or changing demographics. The sheer number of low-frequency but serious side effects can make the information unmanageable and, frankly, uninterpretable for most candidates, leaving them completely overwhelmed.
So what's the answer? Prioritization.
Yes. The key is to shift from a comprehensive list to a prioritized, patient-centered discussion of the most material risks to them. What worries them the most? What impacts their life? And the consequences of graft failure also differ dramatically depending on the organ. A failed kidney graft, for example, allows the patient to return to dialysis, potentially awaiting another organ for months or years, although subsequent transplants are more hazardous. In stark contrast, failure of a heart, lung, or liver graft usually leads to death very quickly unless an immediate replacement can be found. There's virtually no margin for error in decision-making there.
A profound difference.
A profound difference, yes. That immediate life or death consequence changes everything.
It's clear that the standard informed consent process is truly stretched to its limits here. We hear terms like deemed consent or broad consent. How do these variations factor into such critical decisions, and what are the inherent limitations even of informed consent itself when dealing with such profound medical scenarios?
Well, the language around consent reflects this immense complexity. And these variations highlight the legal, ethical, and practical nuances we have to contend with. We have several conceptualizations. Informed consent is what we've largely been discussing. It requires the patient to receive and understand adequate information about a course of action's risks. This is the gold standard we strive for. Then there's deemed consent, which essentially assumes a patient agrees unless they explicitly or implicitly express otherwise. Rebutting this often requires clear evidence. And broad consent allows a range of activities under a generic agreement, though it has limitations, for instance, regarding the future use of health data for purposes not initially specified. And finally, the Human Tissue Act 2004 even uses the term appropriate consent, defining the standard of consent specific to particular circumstances. This variation, as the Act acknowledges, has led to a bewildering variety of forms of consent.
That's a bewildering array of terms, as you said. So from informed to deemed to appropriate, it's clear consent isn't a single monolithic concept anymore. What's the biggest practical challenge for a clinician trying to navigate these different standards in a high-stakes scenario like transplantation?
I think the biggest practical challenge is maintaining consistency and ensuring genuine understanding when the legal and ethical frameworks themselves are so varied and context-dependent. With each conceptualization, questions of adequate information and capacity are paramount. Communication is fundamentally a two-way process. Just as healthcare professionals need to provide all relevant information in a manner that is understandable to the patient with capacity.
The patient has a role, too.
Exactly. The patient also has a responsibility to take note of the information provided and seek clarification where needed. It's an active partnership, and that shared responsibility can be difficult to manage effectively in practice. And while legally essential, informed consent has several practical limitations. Firstly, it cannot, in and of itself, create choices if none exist. If there's only one viable treatment, the concept of choice is somewhat moot. Secondly, it relies heavily on a cultural context that facilitates a particular mode of decision-making or communication. What works in one cultural setting may not translate easily to another. Thirdly, informed consent may lose its impact when the parties involved lack a common interpretative framework, for example, if they approach the decision-making context with vastly different conceptions of illness and its treatment. Simply disclosing all the facts, no matter how comprehensively.
Doesn't guarantee understanding.
Precisely. It doesn't automatically improve interpersonal communication or guarantee genuine understanding. It can sometimes just create a data overload, leading to more confusion. Furthermore, the concept of autonomy itself is not without bounds. It is often shaped by relational factors such as family structure or deeply held cultural and religious beliefs. An individual's decision-making is rarely entirely isolated. Moreover, autonomy is legally limited where an individual lacks legal capacity, as defined by acts like the Mental Capacity Act. And the ability to understand certain sets of highly complex medical information might also be inherently limited by a range of social factors, like a lack of medical training. Certain knowledge is simply inaccessible to the non-clinician. Clinicians must be acutely aware of all these factors when engaging in the consent process, especially in these high-stakes fields like transplantation.
So, if standard informed consent has these limitations and the Montgomery ruling demands personalized dialogue, what practical recommendations are emerging to ensure truly informed consent is achieved in transplantation? How do we move beyond a mere proceduralized box-ticking exercise? It sounds like we need a robust framework to truly meet these demands.
Absolutely. We advocate for what we call a multi-factor approach, designed specifically to address the unique challenges of transplantation. This approach acts as additional practical guidance to existing frameworks, like the GMC guidelines, to ensure consent is genuinely informed and understood. It rests on three key pillars: understanding risk, effective communication, and robust review processes. First, understanding risk. This is central, as consent is only truly informed when risks are understood, not just disclosed. Beyond objective clinical identification of risks, Montgomery makes it clear that the subjective perception of risks matters enormously. Clinicians must actively understand which donor risks a recipient is prepared to accept, investigating how specific clinical or social factors influence that particular patient's decision. This might mean delving into their family's situation, their career, their personal goals, or their tolerance for uncertainty. The mode of delivery is key here. The how is as important as the what. Information must be presented in a way the patient can comprehend through genuine dialogue. Because knowledge of a fact or a percentage isn't the same as true understanding and appreciation of its implications.
Making it meaningful again.
Making it meaningful, yes. Second, effective communication. Consent is unequivocally a process, not a single event or just signing a form. Information should ideally be provided over time, by multiple healthcare professionals, perhaps specialist nurses, doctors, pharmacists, and in various formats, maybe combining verbal explanations with written materials, digital resources, even peer support groups. Clinical experience consistently shows that patient understanding and recollection can be limited, even with well-presented written information, so repeated, tailored communication, spaced out over time, is vital.
Reinforcement is key.
Reinforcement is absolutely key. This iterative approach allows for questions to be asked and information to be absorbed at the patient's own pace. Third, and this is a distinguishing factor of our proposed approach, are robust review processes. This really emphasizes the institutional dimension. Healthcare professionals need to explicitly identify where they have discretion, that is, room to choose between different courses of action or different ways of presenting information. It's precisely in these areas of discretion that they should engage patients most deeply, using legal judgments like Montgomery as guidance rather than prescriptive rules. It moves beyond mere compliance. It's about making conscious, patient-centered choices. From an institutional perspective, transplantation centers must actively monitor their consent processes. This includes a review of specific internal procedures, regular staff training on consent, both its format and frequency, collecting feedback from all relevant actors, both patients and staff, and robust data collection on these aspects. This shouldn't be a mere administrative box-ticking exercise. It's about ensuring good communication and dialogue are fundamental parts of patient care. Clinicians should proactively ask questions like, what matters to you most? To understand patient priorities.
And check they've actually understood.
Yes, take active steps to verify their comprehension, perhaps by asking patients to articulate their understanding in their own words. Finally, given that listing for transplantation can occur weeks, months, or even years before the actual procedure, consent should be reaffirmed periodically, say, every 6 months, and again, immediately prior to transplantation. This is crucial because the patient's condition and the risk-benefit balance may change significantly over time, potentially influencing their willingness to accept, perhaps, a higher-risk graft. Now, implementing these recommendations, of course, requires significant resources and dedicated training in busy clinical environments, but the benefits in terms of truly informed consent are, I believe, invaluable.
Professor Imam, alongside this evolving legal landscape of consent, there's another significant force shaping medical practice: defensive medicine. So what does it truly mean to engage in defensive practice, and how widespread is this phenomenon amongst clinicians today?
Right. Defensive practice refers to clinicians modifying their approach not primarily for optimal patient care, but rather to reduce the risk of litigation or complaints, often stemming from concerns about negative patient outcomes. It's a widespread issue, impacting various specialties across the board. This isn't just a theoretical concept. Many clinicians readily acknowledge practicing defensively in their daily work, sometimes almost instinctively. It can manifest in several ways. One primary form is over-documentation, where clinicians write screeds and screeds, as some describe it, to cover themselves, sometimes at the expense of genuine patient interaction. These notes are often driven by perceived legal requirements rather than purely clinical utility, which can create a lot of noise that actually detracts from a meaningful clinical picture. It becomes more about protecting oneself than clear communication.
Almost counterproductive.
It can be, ironically. All that detail can obscure critical information. Another common example is ordering unnecessary diagnostic tests and monitoring. This involves ordering more tests than are clinically necessary, often linked perhaps to patient pressure or just a generalized fear of adverse outcomes. In obstetrics, for instance, electronic fetal monitoring, EFM, is a frequently cited example. It's often used even when it has no proven clinical value in low-risk pregnancies, simply for legal documentation, just in case something goes wrong.
A just-in-case test.
A just-in-case test, exactly. Which, while intended to protect, can lead to overdiagnosis, patient anxiety, and even unnecessary interventions. We also see unnecessary procedures or referrals. This means undertaking procedures or making referrals simply to shift formal responsibility for a patient, even if it's not clinically optimal for them. Cesarean sections, especially after a previous C-section, are often mentioned in obstetrics as being performed for defensive reasons. A clinician might think, life is too short for this hassle, choosing a C-section to avoid any potential for a complicated vaginal birth that could lead to a complaint or litigation.
A pragmatic choice, maybe, but not necessarily best for the patient?
A pragmatic choice driven by fear, yes, rather than purely clinical need.
It sounds like there's a strong subjective element to what constitutes defensive. What one clinician regards as defensive, another might see as perfectly appropriate caution, Is that part of the challenge in even measuring how widespread it is?
Absolutely. That subjectivity is a huge part of the challenge. While many clinicians acknowledge practicing defensively, and some studies suggest it is frequent in general practice and in their own individual work, there's an interesting ambiguity. Some deny it entirely, viewing it as an unjustifiable departure from clinically optimal care, or even a scarecrow, an overblown idea.
Yeah.
The line between appropriate caution, which is always necessary in medicine, and defensive practice is often a subtle matter of clinical judgment and context. This subjectivity makes it difficult to quantify precisely, but it doesn't diminish its pervasive influence. It's a very gray area.
It sounds like defensive practice isn't just about a direct, rational fear of being sued. What are the deeper cultural and institutional forces at play that contribute to this phenomenon, often in ways clinicians themselves might not fully recognize?
You're absolutely right. While personal experience of litigation can certainly be a driver, the pervasive nature of defensive practice extends far beyond this. It seems to be driven by interwoven cultural and institutional factors that create a fertile ground for it. Let's first consider the cultural factors. These operate at what we might call a macro system level, essentially, the broader societal beliefs and values that permeate our healthcare environment. The concept of defensive practice has been so widely broadcast, talked about in the media, discussed amongst colleagues, that it has created a sort of collective anxiety among clinicians. This narrative fuels an individual fear that often transcends the objective risk of litigation, leading clinicians to overestimate their personal and professional risks if there's a bad patient outcome. It becomes almost an embedded anxiety in the profession.
So it's not just the direct legal threat, but this broader fear of being singles out, of being the guilty individual. Does that blame culture you mentioned, does that actually make it harder for the healthcare system to learn from mistakes? Because everyone is focused on self-preservation.
Exactly. A significant driver is what we often call a blame culture. The logic of individual blame, inherent in many legal systems, particularly in Western societies, contributes directly to this. It's often easier, institutionally and perhaps culturally, to identify a guilty individual when something goes wrong than to uncover the complex underlying systemic issues that actually led to an error. This cultural focus on individual blame contributes directly to clinicians feeling the need to protect themselves by adopting defensive behaviors. And yes, you're spot on. It absolutely inhibits learning. If the first instinct is to find fault, then open reporting and analysis of errors, which is crucial for systemic improvement, becomes incredibly difficult. People clam up. Then there's the influence of marketization and consumerism, a societal shift towards viewing healthcare through a market lens where the citizen is best seen as a customer has profoundly impacted the clinician-patient relationship. This ethos fosters a sense of risk, with patients sometimes perceived as risk generators who might challenge medical authority or demand specific tests and treatments.
Patients as consumers.
Patients as consumers, yes, which can pit patient and provider against each other, and defensive practice emerges as a self-protective strategy. We sometimes see this anecdotally, where patients from higher socioeconomic groups are perceived as particularly demanding, perhaps more likely to complain, further fueling this dynamic. The very philosophical underpinnings of modern medicine also play a role through the biomedical model that's the traditional view that disease is primarily a biological phenomenon, separable from social or psychological factors. The often unstated assumptions of this model imply that identifiable truths about diseases can be discovered, and doctors should always provide the correct diagnosis or therapy. This black or white dichotomy, this idea of perfectibility,
Creates an intolerance of error.
precisely. It creates an intolerance of error, both in the public and, importantly, in clinicians themselves. It induces a shame response when outcomes are imperfect. This further fuels defensive behaviors irrespective of actual legal threats. If every problem has a correct solution, then any deviation or imperfection feels like a personal failure. Moving to institutional factors, these are the formal structures and practices within healthcare, what we might call the exosystem. These also play a crucial role. Media influence, for example, is significant. Media fascination with malpractice cases, particularly inflammatory reporting of controversies and tragedies, contributes to a generalized suspicion of clinicians. This negative public perception can influence decision-making and drive defensive practice.
And social media adds to that.
And social media, enabling patients to compare care and share experiences instantly, further amplifies this pressure and scrutiny. Specific legal institution principles can also entrench defensive practice. Once it becomes normalized, principles like the Bolam principle, which judges care based on prevailing local practice, can actually make less defensive practice appear maverick and hard to justify if defensive approaches are the norm.
So the system reinforces itself.
It reinforces existing defensive behaviors, yes. It makes it harder for clinicians to step away from them, even if they want to. You're trapped by the very standard meant to protect you. Finally, healthcare policies and practices are major drivers. Organizational models, such as the hospitalist approach, which can lead to less patient face time and thus perhaps weaker patient-doctor relationships, or the shift to hospital trust in the UK, with leaner and flatter managerial structures and performance indicators focusing on individual responsibility, can diminish doctor-patient relationships and increase individual accountability. This contributes directly to clinicians' unease and defensive practice. NHS codes of conduct, for instance, explicitly state that nurses are personally accountable. Furthermore, policies that position the patient as a consumer, like the UK's Patients' Charter back in 1991, which gave patients new rights, were actually found to increase nurses' concerns about legal accountability, as higher patient expectations became a driving factor. Even medical training itself can contribute through its informal curriculum. Trainee clinicians observe and work alongside senior faculty, often internalizing defensive practices they see modeled.
Learning by example, but maybe the wrong example.
Learning by example, exactly. This peer influence can contribute to variations in practices like EFM or C-section rates across different hospitals, indicating a learned behavior rather than purely evidence-based practice. Junior staff in particular often feel vulnerable and pressured to order more tests or referrals simply to protect themselves.
These widespread drivers paint a really concerning picture. What are the tangible effects of defensive practice on our profession, our patients, and even our own well-being? It sounds like it goes far beyond just adding an extra test here and there.
The impacts are indeed far-reaching, affecting the quality of care, professional morale, and the very foundation of patient relationships. It's quite corrosive. One significant effect is the erosion of professionalism and autonomy. Clinicians often feel their professional judgment is undermined as decisions become driven by extraneous factors, paperwork, rigid guidelines, rather than purely clinical reasoning. This de-skilling and loss of autonomy leads to reduced job satisfaction and ultimately can contribute significantly to burnout. Midwives, for instance, have strongly linked defensive practice to the medicalization of birth, perceiving it as a shift of clinical authority to obstetricians and a disempowerment that negatively impacts their ability to provide optimal woman-centered care.
Feeling like a cog in a machine.
Precisely. Feeling like a cog in a machine rather than an autonomous professional capable of nuanced judgment. Then there are significant negative impacts on patient care. Defensive practice also leads to unnecessary interventions, whether treatments or diagnostic tests. These can potentially cause direct harm to patients. Think about exposing children to painful procedures or repeated imaging with radiation, and they incur excess costs for the entire healthcare system. It can also exacerbate health inequalities, as perhaps more assertive or demanding patients, often from higher socioeconomic backgrounds, are more likely to push for and receive these unnecessary interventions, consuming resources that might be better allocated elsewhere. Furthermore, there's a tangible reduction in empathetic care. Time spent on formal procedures and extensive documentation is time taken away from direct patient care and crucial emotional support. Clinicians can become more focused on correct documentation, covering themselves, than on responding to real individual patient needs. In some extreme cases, defensive practice leads to the avoidance of high-risk patients or areas of care. Some clinicians might actively avoid certain patients perceived as unreliable or litigious, maybe specific socioeconomic groups or even occupational groups like lawyers or teachers, or even shy away from high-risk specialties like obstetrics, intensive care, or emergency medicine, simply to minimize their perceived exposure.
That's worrying.
It is, and paradoxically, an over-disclosure of risks and harms in communication driven by defensive concerns can cause needless anxiety and actually impair patients' ability to make a truly informed choice. It can overwhelm them with information without necessarily improving their understanding or helping them weigh the options appropriately. This also results in damaged communication and relationships. Defensive practice largely has a negative impact on communication, shifting relationships from empathetic partnership towards something more adversarial. Clinicians focused on minimizing risk struggle to engage empathetically, perhaps constantly aware of potential legal ramifications. This fundamentally undermines trust, which is the absolute core of effective clinician-patient relationships. It can be particularly damaging to roles like that of a midwife, whose advocacy for women depends entirely on a trusting relationship. We also see rigid adherence to guidelines. Now, clinical guidelines are important. They can certainly act as a safety net and promote best practice, but defensive adherence can lead to overtreatment and a mechanical, protocol-driven approach that stifles individualized responsive care.
Treating the guideline, not the patient.
Treating the guideline, not the patient exactly. It can mean treating people as impersonal processes rather than unique individuals with unique needs. In extreme cases, and this is deeply concerning, some clinicians might even falsify documentation to align with guidelines whilst making clinically sound decisions that, for valid reasons, deviate from rigid protocols. This creates a dangerous disconnect between what's recorded and what's actually done.
A serious ethical
A
breach.
very serious ethical concern, yes. And finally, there's a significant emotional toll on clinicians themselves. Defensive practice leads to feelings of guilt, regret, chronic anxiety, and demoralization, often linked directly to that loss of professional autonomy. Clinicians report feelings of frustration, fear, and a profound loss of confidence in their abilities, creating a vicious cycle where insecurity drives more cautious and potentially suboptimal decisions. The pervasive blame culture makes clinicians fear their name being dragged through the mud or being seen as incompetent by their peers, leading to isolation and significant distress. It's a heavy burden to carry.
Bringing this back to our orthopedic audience, Professor Imam, how do these complex principles from Montgomery and the broader consent landscape manifest specifically in orthopedics? We've touched on the profound ethical shifts since Hatcher v. Black. What about the day-to-day challenges of applying patient-centered consent in our specialty?
Well, the Montgomery judgment certainly has significant implications for orthopedic professionals, mandating, as we've discussed, a deeper engagement with patients and their individual values. However, applying it creates specific challenges in our field, particularly given the often elective nature and varied outcomes of many orthopedic procedures. One immediate consideration is the resource implications. Whilst Montgomery provides a robust legal justification for patient-centered care, which I believe most orthopedic surgeons genuinely aspire to deliver, it also creates potential for increased time pressures. Empirical evidence suggests doctors do report longer counseling times, and a significant proportion identify a lack of time as a primary barrier to full Montgomery compliance. This can contribute to professional stress and lower morale if not adequately resourced. However, it's worth noting some studies also suggest that the cost of spending that extra time on thorough consent could actually be offset by reduced legal claims down the line. For operations like arthroplasty, the estimated annual savings from reduced claims could potentially be substantial, perhaps even in the realm of $10 million nationally.
So it's not just about compliance, but potentially about improving patient outcomes and reducing litigation in the long term. That's a compelling argument for investing that time.
It is a compelling argument, exactly. A major area of impact is the dialogue on alternatives. Orthopedic patients frequently have multiple treatment pathways open to them. This could involve choosing between different types of joint replacements, various surgical approaches for fracture fixation, or even deciding between operative and non-operative management. Montgomery strengthens the legal duty to fully discuss all these alternatives, including their specific risks, benefits, and critically how they align with the patient's unique lifestyle and desired outcomes. Beyond just discussing alternatives like different joint replacements, Montgomery in orthopedics really pushes us to consider unique patient values. For instance, explaining the long-term implications of one particular type of knee prosthesis versus another for a marathon runner, versus someone primarily interested in pain-free daily mobility becomes absolutely critical.
How do you tailor that discussion when a patient's entire identity might be tied to a specific physical activity that could be impacted, or their job demands specific physical abilities? That sounds really challenging.
It requires a deep dive into their personal circumstances, their hopes, their fears. It's not a quick chat. And a less explored, but I think highly relevant extension of Montgomery is the duty to disclose risks associated with diagnostic uncertainty. This is even when no procedure is performed on the body. This is particularly pertinent in orthopedics, where diagnoses can sometimes be complex, evolving, or difficult to pinpoint precisely think about chronic pain conditions without clear pathology, or the diagnostic process leading up to an exploratory arthroscopy. Clinicians may face uncertainty about the extent to which they should inform patients about the diagnostic process itself, its inherent uncertainties, and potential alternative diagnoses that are still under consideration. This area currently presents a bit of a gap in legal clarity and requires very careful consideration from orthopedic teams.
So you're consenting them not just to a procedure, but potentially to a diagnostic journey that might not have a clear endpoint initially.
In a way, yes. That's a good way to put it. Managing expectations around that uncertainty is key. Finally, despite these significant legal shifts, studies even in trauma settings where decisions are often time-critical show that patients can still struggle to identify all the material risks following a consent discussion. This highlights the ongoing fundamental challenge of achieving genuine patient understanding, not just mere disclosure. Orthopedic teams must, therefore, find innovative and perhaps repeated ways to convey complex information about surgical risks, expected recovery timelines, and potential long-term implications of various interventions, or indeed, non-intervention.
So just giving them the leaflet isn't enough.
Definitely not. This might involve visual aids, specialist nurses providing follow-up discussions, or using shared decision-making tools to actively verify comprehension.
Given the pervasive nature of defensive practice we discussed and the specific pressures in orthopedics elective surgery, patient expectations, what actionable strategies can orthopedic professionals and institutions employ to maintain optimal patient care without succumbing to that excessive, potentially harmful caution driven by litigation fears?
Well, mitigating defensive practice in orthopedics requires a truly multifaceted approach. It has to focus simultaneously on cultural shifts within departments, enhanced communication strategies, and robust internal systems. We believe that applying the multi-factor approach we discussed earlier, understanding risk, effective communication, and robust review processes, provides a strong and actionable framework specifically for orthopedics. This means going beyond simply using standard consent forms for orthopedic procedures as a one-off event. Instead of just stating a general infection rate for a knee replacement, for example, it involves discussing how that risk might be personalized to the individual patient based on their specific comorbidities, perhaps diabetes or obesity, and crucially, how those risks intersect with their lifestyle choices and priorities. This fundamentally requires asking the patient what matters to you most to truly understand their priorities, whether it's returning to high-level sport, being pain-free to play with grandchildren, or simply having undisturbed sleep.
Getting to the heart of their goals.
Exactly. Furthermore, orthopedic patient journeys are often long, spanning from initial consultation right through to post-operative recovery and rehabilitation. Therefore, communication about risks, recovery expectations, and potential complications like implant failure or maybe nerve damage during complex spinal surgery needs to be an ongoing dialogue, not just a single, isolated event before surgery. This has to involve the entire care team: surgeons, nurses, physiotherapists, maybe even occupational therapists. It's crucial to acknowledge and actively address patient recollection limitations by repeating and reinforcing key information over time and perhaps in various formats. On an institutional level, orthopedic units must implement robust internal review processes for consent. These need to move beyond simply box-ticking towards genuinely substantive obligations. Surgeons and healthcare professionals should be actively encouraged, perhaps even trained, to identify areas where they have clinical discretion in tailoring information and approaches. This might involve peer review of consent conversations, where colleagues observe and provide constructive feedback, or regular staff training on advanced communication skills, focusing specifically on how to convey complex information effectively and empathetically. To counter the pervasive blame culture, orthopedic departments really need to foster an environment that actively supports clinical judgment and encourages learning from adverse events rather than immediately seeking individual culpability.
No blame culture, ideally.
A just culture, perhaps. This can significantly help reduce the chronic anxiety and loss of confidence that often drive defensive behaviors among clinicians. Collecting feedback from orthopedic patients about their understanding of consent and using this directly to inform staff training on effective communication is essential to close that loop and see how well we're actually doing. Finally, whilst guidelines are undeniably crucial for ensuring quality and safety, orthopedic practice must actively avoid becoming overly protocol-driven to the detriment of individualized care. We need to encourage a culture where clinicians feel empowered to use their extensive experience and judgment. This includes clearly communicating with patients about any deviations from standard guidelines, provided it is clinically sound and well documented. This also applies to managing complications like, say, an intraoperative instrument breakage. While not necessarily negligent, transparent discussion with the patient is absolutely vital to maintain trust and ensure informed decision-making even when unexpected events occur.
Building trust even when things go wrong.
Precisely. It's about building trust, even when things don't go perfectly according to plan.
What a truly profound deep dive into the complex world of consent and defensive medicine. Professor Imam, your insights highlight just how much the landscape has shifted, demanding more than ever from us as medical professionals.
It's true. The journey from a paternalistic approach to genuine patient partnership, driven by landmark judgments like Montgomery, fundamentally changes our responsibilities. We've explored how in fields like organ transplantation, the sheer volume of information and patient vulnerability create immense challenges. And critically, we've seen how defensive practice, often driven by deep-seated cultural and institutional factors beyond direct litigation fears, can subtly erode professionalism and impact the quality of patient care.
So, for our orthopedic audience, the takeaway seems clear. The quality of our dialogue, our ability to understand risk through the patient's individual lens, and the robustness of our institutional support systems are paramount. These are the cornerstones of ensuring truly valid consent and combating the often invisible pressures of defensive medicine, allowing us to deliver the best possible patient-centered care you strive for every day. If this deep dive has sparked your thinking and provided valuable insights for your practice, please do consider sharing this with a colleague and rating us on your favorite podcast platform. And finally, a provocative thought for you to mull over. Perhaps the true measure of modern orthopedic practice lies not just in surgical precision, but in the quality and depth of the conversation we have with our patients before a single incision is made.